other abnormality in these two spot films.
So what is your conclusion?
So I can see some narrowing in the second part of the duodenum medially. I would suspect some extrinsic abnormality, putting a compression there and causing a narrowing. This could be in the first. This could be in the at the ampulla or the pancreatic head.
Very good. So what is your differential for this?
And extrinsic compression from adjacent viscera, likely from the pancreas.
16-year-olds, sort of.
Oh yeah, 16 years old. So this could be an annular pancreas.
Okay, excellent, well done. So I'll take over because of the time factor. Well done. Now, what has been described here is that if you see here, there is an indentation here, which is circumferential type of indentation, but more marked on the medial side. On the second part of duodenum, with that, the mucosal folds are normal. So this is annular pancreas. Now, annular pancreas is a very important exam field for in the pediatric worlds, where it is what we call the double bubble sign, etc. Even intrauterine ultrasounds can be asked for double bubble. You know, on ultrasound, there will be fluid and fluid. On a plain film, there might be air and air. On the other hand, annular pancreas can present in an adult. And this one was 16 years old. So going back to embryology, please remember what happens is that pancreas develops from two birds. One is the dorsal bird, and the second one is the ventral bird. And we'll come back to this because I'll teach you when we will do pancreas, pancreatic divisum, etc. But this thing actually shifts on this side, as in the medial side. And sometimes part of the tissue keeps surrounding the second part and can cause sort of obstruction. At times it is just an incidental finding out. So, well done. Okay, because of time factor, some of the films I will ask you, sort of leading questions. What do you think is happening here? This is, what kind of examination is this, number one?
This is a contrast study of the double contrast study of the upper GI.
And what is this?
This is the duodenum.
Okay, so this is a contrast study, the spot film of duodenum, and what is happening here?
There is pooling of contrast in the second part of the duodenum. Oh, sorry, the first part of the duodenum. And I can see some outpouching also superiorly, which is contrast filled.
So what is your conclusion for this?
This is a large ulcer formation which is protruding out.
Okay, so good thought. Having said that, if you see this is the lumen, the contrast goes out and is sitting here. So there is a sort of a narrow connection between this and this. So your thinking is absolutely fine, but what else can it be?
It can be a duodenal diverticulum as well.
Is this a site of duodenal diverticulum?
No.
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 What else?
I'm not sure.
Okay. This is a different patient. Over to you. What kind of examination has been done?
This seems to be a single contrast study of the upper GI. And I can see some Contrast outside the GI in the right upper quadrant. That linear, the linear lucence is there,
Okay. So what is your conclusion?
Does this patient has any surgery?
No.
And then I'm not sure. I cannot think of.
Okay. In which posture has this film been taken?
This is upright.
Okay. Coming back, actually we are seeing similar examples. This is a different patient. This was a double contrast study, spot films of the duodenum. There is a fistula. And this fistula, there is a structure here, and you have to stretch your imagination what can happen. This is, the first part of duodenum, and next to it is gallbladder. So in chronic cholecystitis, what happens is that there can be fistulas between the, duodenobiliary fistulas. And this is poorly, distended, chronically inflamed gallbladder. The second film is similar. And here you can see that contrast goes, actually it is going into the biliary tree. So in contrast studies, two things are very, very important. First of all, try to orient yourself which kind of film has been taken at that point. Is the contrast at the correct location or not? So this is a biliary duodenal fistula. And you might have seen similar cases on CT scan. But because I know that the current generation don't see bariums. And please remember that bariums do come in the exam. And particularly in this COVID crisis, by the way, everybody, even in UK, has done a lot of bariums. Because aerosol generating procedures, etc. There were some protocols about it. So bariums are still in the curriculum. You can be asked bariums. Your eyes are not trained. I am going to particularly concentrate today also and in the large bowel also. I'll show you a lot of bariums because I know you people see a lot of CT scans. So this is what it is. Okay, this is your last film. Now I am showing you a single contrast, this time spot films, and this is the duodenum. Some of these films are what I call, just to develop your eyes, pattern recognition. What do you think is this and this is the same thing? Just give me this answer.
This is an ulcer from the duodenum.
Excellent. So this is a projecting ulcer. You see, means that the ulcer is intramural and it is projecting outwards. So this is a projecting ulcer. Okay, candidate one, thank you very much. Well done. And I'll go to candidate two. Because of time factor, we are going to switch over from candidate to candidate very quickly today. And it's a sort of an experiment from my side. Are you with us, candidate two?
Yes.
Okay, so what do you think is this? Once you describe it, then I will show you another film also. Name the examination and describe this finding, and then I'll show you another film.
So this is a water-soluble contrast study, and there's an area within the duodenum where the contrast appears to pull into it.
Sorry, where is this? Anatomy-wise, where are we here?
I initially thought it's in the duodenum, but it may actually be in the stomach.
Okay.
So, so if it's in the stomach, it will be projected in the greater curvature lesion. It appears to be fully contrast opacified, well defined.
Okay. So I will show you a second film now. What is your conclusion?
Is it something that's causing a feeling defect within the stomach?
Okay.
It appears to be well defined, well circumscribed. It may be a lesion within these.
Right. Okay. Basically, I'm showing you different examples just to develop your eyes on barium. Basically, what is happening? That there is a pool of barium here. If you see, the rugae are sort of radiating outwards.
Okay. Could it be an ulceration, a benign sort of ulcer within the stomach?
Rugae are removed of barium. When I show you, excellent. So this is a giant projecting ulcer. So the eye see what the mind knows, and once you see it, you will not miss it. So this is a giant projecting ulcer which is projecting outwards, and so this is what it is. Okay, well done. Now, this is a projecting duodenal ulcer, and here what is happening, that this kind of a film can come in the CT can come in the exam, and you can see that there is fat stranding around this region, and actually you can see something going into the wall. So just wanted to show you similar finding on CT scan. So similar to the previous case, but of course this is in the duodenum. Projecting ulcer, large projecting ulcer. So this is what happens when there is an ulceration. The rugae, they project towards it, and projecting ulcers can, because they are intramural, they project outwards. In a profile film, they will project outside the contour of the lumen. Over to you, please.
So these are select portovenous phase imaging of the upper abdomen. The stomach or distal stomach and pylorus appears to be diffusely thickened, and transmural thickening of the distal stomach with some nodularity in the proximal aspects of the stomach. On the lower images, I can see some fat stranding around the stomach. I cannot see any. There is a locule of gas in the right upper image, which may be pre-gas. So I'd like to sort of, in my routine practice, I'll look at this further. This may be a site of local perforation. I can't see any surrounding free fluids. So my top concern is if this is a gastric perforation, secondary to ulceration, which may be inflammatory or malignant.
Okay, so that's fine. What do you think? How will you describe this? This is the antrum and the pyloric canal. How will you describe this thickening?
So it's quite irregular. There appears to be some mucosal irregularity. There's also thickening of the submucosal area.
This thickening of the submucosa, what is the attenuation of this? For example, here,
It's quite low.
And what does it tell you? Can it help you reach a diagnosis?
So it could, so low attenuation could imply that it's sort of fatty in nature, or ischemic.
Okay, I'll come back to this point. Now, please also remember that you did well when you picked up this free locule, and in the examination, you are going to ask the examiner that I want to confirm it on to change the window. Usually, people use either lung window, and some people use the bone window actually to pick up pneumoperitoneum. Whatever if the examiner wants or has got time, will allow you. Otherwise, they will say, okay, it's fine. This is confirmed. So if you see here, I'm going to teach you something on this submucosa and the attenuation of it. Please remember now, candidate 2, in your differential, you told me that this will be either a malignancy or an inflammatory process, right? And there is a perforation, fine. But let us take help of this attenuation of the thickening to further narrow the differential. And otherwise, your findings are absolutely fine. There is fat standing, there is locule. So, if you go back to your histology, this is the histology of the stomach. This is the mucosa. Then there is submucosa, then muscularis, subserosa, and serosa. Serosa is the peritoneum, the visceral peritoneum. Now, this is the case which I was showing you. Look at the attenuation inside, and as something which is enhancing here, let me change my mouse to arrow, which will be better for you people. Now, if you see, look at this mucosa and develop your eyes on this. Mucosa is showing enhancement. And look at the submucosa, look at the density. And as you have pointed out, this is low density. And low density means water, think water, right? And when you see this kind of finding, this is more in keeping with inflammatory or infectious conditions. And on the other hand, when there is some enhancement, soft tissue density, more likely to be neoplastic, like carcinoma, lymphoma, or metastasis. So this is not an absolute specific discriminator, but a useful tool on a CT scan. So this is another example just to make the same point, that this is a ulcer which has perforated because there are locules here. And again, in the submucosa, you can see low density. On the other hand, this is a case of carcinoma. And if you can see the mural thickening and look at the density there, and you will agree that the density is high. Okay, candidate 2, spot diagnosis. What is this?
Duodenodiverticulum.
Right. Which part of duodenum is this?
Second part.
Second part. Now, duodenal diverticuli can be at various locations. The most common is the second part, and they project towards the pancreas. And you must have seen them so commonly, on a CT scan or MR. So it is nothing important clinically, but having said that, if a gastroenterologist is doing an ERCP, they have to understand that there is a diverticulum. You don't want them to go in. So this is an MR scan where you can see fluid level, and you are worried what is happening. Once you know that there can be a diverticulum, it's easy. And this is a coronal CT scan of the same patient, because the cut is going posteriorly. In the dependent portion, there is a bit of debris inside. Clinically speaking, it's not very important thing, but the only thing is that you should understand so that you do not mix it up with any other condition. Okay, I will, because of time factor, now we are going to, okay, you take, tackle that as your last case, candidate 2.
So this is a contrast.
Before you continue, all of you, can you please listen to this very carefully? Because I am going to teach you something here which is very important for your exam. It's a very difficult one, this one. And this concept, because you people don't do bariums, still comes in the exam. So I'm going to do a bit of teaching, taking the help of this case. So please concentrate on this one. Over to candidate 2.
So this is a upper GI contrast study with a spot image project of the duodenum. There appears to be some narrowing of the second and third aspect of the duodenum, and the space surrounding the inner space surrounding the duodenum appears to be slightly expanded. I wonder if there's a mass which is compressing the second and third part of the duodenum externally, and in this location I'll be concerned about a pancreatic head mass which is causing stenosis rather than an intrinsic mass within the bowel. So my primary diagnosis would be a pancreatic head mass which is compressing the second and third part of the duodenum externally.
Excellent. You can mute yourself. Candidate 3, be mentally ready to raise your hand, but I'm going to do a bit of teaching on this case. Now, this case, I'm just showing you because maybe 25, 30 years ago, this case was an exam case. Now, nobody is expected to show you. Basically, what is happening, as you have picked up, that there is an extrinsic mass which is infiltrating the duodenum. And extrinsic mass which is infiltrating is causing some findings. Now, nobody in this era should show you a barium study for this, obviously, and no pancreatic carcinoma should be. This was known as a reverse 3 sign. If you see here, there is an extrinsic impression here. You can understand that the ampulla is here and other bits is here. But if you look carefully, this also tells you when an extrinsic mass is next to what we call a lumen, may it be duodenum, stomach, large gut, etc. What will happen that there will be an impression or compression, extrinsic compression. Then what happens is that these masses, they produce a bit of desmoplastic response, fibrosis. And you can see these spikes of barium, they are projecting outward into the mass. So this is quite, sometimes you might even see that the mucosa here might be fixed. In your exam, again and again, a few cases come in this category. I don't want to tell you more. I am going to show you a few cases. Now, is candidate 3. Can you raise your hand, please? I think there is a technical issue there. So I will go to candidate 4, please. Please raise your hand, candidate 4. Actually, now I can also see candidate 3. Candidate 3, yeah, I am with candidate 3 now. So candidate 4, please wait.
Yeah, I'm here.
Now, what is happening here in the colon? This is a barium enema examination. What is happening? How will you describe this?
This is a double contrast study of the enema of the colon, showing irregular mucosal thickening with a loss of normal mucosal pattern and luminal narrowing of the transverse and and I could spot there are few ulcers in the colon, in the descending colon, mostly representing in the form of retained contrast. So I'd be worried about neoplastic process. Mostly could be secondary to inflammatory bowel disease due to the presence of those ulcers. And I'll take the case further, I'll do CT for better assessment.
Okay. If you see here, this is a case of candidate 3. I'm going to mute you. There's a bit of disturbance coming, so I'm muting you. Now, if you see there is a barium enema film. On this barium enema, there are multiple diverticuli. That was not the point of discussion. Now, if you see here, this is the transverse colon. On this transverse colon, there is an extraneous compression or impression. So something is sitting outside. And if you look carefully, there are some spikes of barium which are going outside. So something is sitting here. Now, if you look carefully, there is something here. And I am again with candidate 3.
Yes.
What do you think is this? What do you think is this?
This is linitis plastica, the stomach shadow.
Okay. So now, if you see here, this is a barium meal examination or follow-through examination of the same film, same case, where now you understand what is happening. There is loss of distensibility of this stomach, which is classical for linitis plastica. But the teaching point here or learning point is that how it has caused external or extraneous indentation of the transverse colon. Now, with these two examples, I am now showing you a case which has come in the exam many a times and even now is a sort of an exam case for you. Can you tackle it, candidate 3?
This is a double contrast barium enema. I can spot that there is extrinsic compression of the sigmoid colon with mural irregularities. I could see surgical clips. There is narrowing of the colon as well with so I think that might be, if this is a female, I would think of endometriosis as the cause of surgery.
71-year-old?
Yeah. Other possibility.
Excuse me, your thinking is good because you are thinking on what kind of surgery, right? So I'm giving you 71 years old, previous pelvic surgery. Over to you.
Maybe colonic cancer, for colonic cancer, or.
So this is a female.
She is a female. Hysterectomy might be the cause.
Okay. So conclusion, what is happening here? What is happening here?
I think this is an extrinsic compression from the nearby uterus, secondary to recurrence, maybe, or fibratory.
Okay. I'll take over. This is a case of classical exam case. Many times it has come in the exam. And similar case will also come in MR, where there is metastasis sitting here. And this is a case of ovarian carcinoma, which has recurred. And what happens when metastasis, this is the rectosigmoid junction close to that. When metastasis will sit here, this is the same phenomena which we saw on the pancreatic carcinoma film. So it will cause extraneous impression or compression here. Now, if you see, there are spikes and it will cause a bit of fibrosis. So spikes of barium will go into the mass. If you stretch your imagination, this is where it must be sitting, and this is where it must be sitting. If you see the mucosal folds, they are abnormal and they become actually fixed. And there is a sign in old radiology which we call striped colon sign. So these mucosal folds, they become fixed there. So this is a film of metastasis from ovarian carcinoma. Now, I will just show you a film to tell you so I am now projecting a case of ovarian carcinoma metastasis, and candidate 3, I hope you can see my screen, right?
Yeah, I can see it.
Okay, so I will continue with my teaching point there. Now, if you see here, this is the rectum. Now, this is the rectosigmoid. And you can see this intermediate signal intensity. Now, remember this word, intermediate signal intensity. Usually, this is, malignancies will have this signal intensity. And this thing is sitting on the sigmoid colon. And here you are. All of this is metastasis, actually. Let me show you a sagittal which will make everything clear. This is the rectum. And you can see that this is the rectosigmoid. And this is a classical image for you, where you can see that there is a mass here sitting here. It is intermediate in signal intensity. If you look carefully, look at the lumen inside and look at this wall. This wall is different as compared to the other wall. And you can understand that this metastasis has actually gone inside. So this is how it will produce. Look at this metastasis and look at this lumen and how it is adherent and how it will produce fibrosis, etc. And on this coronal also, similar finding can be seen here. So I'll come out of this. And go back to my okay, candidate 3.
Yes, doctor.
Patient, excuse me, because of time factor, I'm going to ask you a leading question. This patient is a 32-year-old female, pain and melena off and on. And do you see anything here?
Yeah, there is extrinsic, there is irregularity, single wall irregularity of the colon with spikes, and the rest of the colon is unremarkable. I think this is secondary to extrinsic compression or extrinsic lesion. Given the history of melena on and off in a female in the reproductive age, I'd consider a possibility of endometriosis.
Excellent, well done. So I'm going to mute you, and well done, you have done very well. Now, candidate 4, be ready for. So I have unmuted you. Please stay with us, candidate 4. Now, this patient, you know, endometriosis is an exam case. They can show you endometriosis on a barium, and there are various sites where it will adhere. Rectosigmoid is one of the classical sites, and just like what we have learned previously. On the other hand, it can be ileocecal also. So this is another example. Okay, candidate 4. This is your case. This patient has had a hysterectomy, and this patient is 34 years old. The patient presents with rectal bleeding. Over to you.
Okay, that's the multiple sagittal imaging T2 images in which I can see there is low signal in the upper wall of the bladder, superior wall of the bladder.
Good, you have picked this up. Good. Anything else?
The rest I can see there is a pivot hysterectomy. I want to look for that. And I can see there is a narrowing of the rectum as well.
Okay, let me tell you. Let me ask you. This is the rectum.
Yes.
So, and then we are coming to the rectosigmoid. What is this?
That could be a deposit or
deposit?
Metastasis.
Look at the signal of this.
The slow signal from T2. So it. That's the 34 female. So it could be endometriotic deposit.
Excellent. You see, this is a classical exam film. What happens in endometriosis is that this is hemosiderin, and hemosiderin is low in signal intensity on T2 weighted sequence. The deposits can be at the rectosigmoid. In this case, the deposits are on the serosal surface of the bladder also. And you can well imagine that this patient, she can have hematuria, particularly at the time of menstruation. She can have also melena. Key point to remember is that hemosiderin is low in signal intensity on T2. When we will do gynae MRs, endometriosis, endometriomas, all of these are exam cases. And there is a hysterectomy. So the patient might have had adenomyosis, and because of that, there is a hysterectomy. So it becomes a sort of a story film. Now, this case, if you look carefully on a barium examination, again, there was a bit of indentation. And final point is, signal intensity-wise, remember these terms. You know, low signal on a T2 is like this low signal, and this is hemosiderin. Intermediate signal is, this one is ovarian carcinoma. Usually malignancies will be intermediate signal. CS cervix, for example, will have a similar signal. So you have to develop your eyes on this signal and this signal. Okay, candidate 4, I'll ask you leading question.
Yes.
Look at the stomach, and are you happy? Everything is normal.
No. I think so. It's intramural thickening.
Okay, you are worried about this thickening. That is fine. My question is now thickening on a CT scan becomes a controversial subject because how much is the distension, etc. But your answer is fine. But I'm not interested there. Can you tell me what is happening here? What is happening here? What is happening here? What is happening here? What is happening here?
Okay, so I think so. It's a pyloric narrowing.
Is this the pylorus? You see, this is the adrenal gland here. You see this thing?
Yes.
What is next to the adrenal gland here?
Antrum.
So what is happening here?
I think so. And if I can see there is a air bubble in it, so
very good, very good.
The fistula, any perforation or fistula?
No. Okay, okay. That's fine. I'll take over. You know the eye see what the mind knows. The same thing. If I show you a bit of a close up, you can see something is happening here, and then there is a bit of fluid. There is a bubble, as you have pointed out, and then this is adrenal. Okay, let me ask you a question. What will you do to confirm the diagnosis? You don't know the diagnosis, but what comes to your mind? You are doing a
MRI or endoscopic ultrasound. No.
Something more simple.
Positioning or barium.
Barium. So this is a barium examination, and what is your diagnosis?
So that's the ulcer. Diverticula.
Diverticula. Fine. Okay, well done. So diverticulae of the stomach. Please remember, most common diverticulae are from the fundus. But there is another diverticulum. The second most common site is close to the lower curvature posteriorly. And classically, it will extend posteriorly where the adrenal sits. Many a times you can be confused because it will be abutting the adrenal. It all depends if there is fluid inside. Sometimes there will be no fluid inside. Even contrast might not be there. So beware of this. This is a known pitfall of a diverticulum. Barium can tell you when the contrast goes in, and you have to do a technique where you make it dependent. So left adrenal nodule, beware of confusing it with a diverticulum of the stomach. This is a more classical, most common diverticulum. Where is it, candidate 4?
It's in the tube.
First of all, tell me that what kind of a film is this? This is a barium meal examination.
That's the barium meal examination.
So what is the position of this patient when this film was taken?
I think so, prone. That's supine. No.
So when there is air in the fundus, means
then it's erected. Sorry.
Correct. Okay, erect position. And in this position, what is your finding? Where is?
So in the fundal area.
Right. So here in the fundus, you can see this diverticulum, and this is the most common site of diverticulum. So this is another example of that kind of a diverticulum which is arising from the lesser curvature. It will go posteriorly, and this is the most common, which is the fundal type of diverticulum. Okay, candidate 4. This is a barium meal examination. What is your finding?
Okay, so that's the way me follow through, in which I can see there is a, I can see the pylorus is rotated downwards. So, I will correlate with the history and with the, and I can see also there is a narrowing of the second part of the duodenum as well.
I'm not at all worried about this. This is simply not distended in this film. What is happening here?
That's the cooling of the contrast in the stomach.
Is it normal? Is the shape normal? What is happening?
The shape is not normal. I will correlate with the history of acute presentation, then it could be an organoaxial gastric volvulus.
So why do you say if it will correlate with an acute history? It can be an incidental finding. Okay, I'll take over. Basically, your diagnosis is correct. But having said that, now I am showing you volvulus of the stomach, which again is an exam case. But please remember the concept. There are two types of volvulus. One is known as organoaxial, and the second one is known as mesenteroaxial. The organoaxial is much more common than mesenteroaxial. But both of them can present usually asymptomatic. So this is usually seen incidentally. And this is very important to remember. And if the volvulus is more than 180 degree, then the patient will present with obstruction. Similarly, mesenteroaxial can also present at times incidental, but more commonly it can present with obstruction. And mesenteroaxial is more common in children. Both of these volvulus can be associated with or without hiatus hernia. So in organoaxial, the stomach twist, if this is the long axis, then the main take-home point is that it twists around the long axis. And the take-home point is that the greater curvature sits upwards. So if you see this case, this is the greater curvature. So greater curvature is superior and the lesser curvature becomes inferior. This is the classical configuration. In a mesenteroaxial, on the other hand, it is around the short axis. So it will twist and then the antrum will sit, superiorly. So this is mesenteroaxial. Look at this, where you can see this is the esophagus. The gastroesophageal junction comes here, and then part of the stomach is sitting upstairs, up in the thorax. So there has to be a hiatus hernia, and it is a paraesophageal hernia, and this one is mesenteroaxial. So just to sum up, this one is a good example of organoaxial, which is not associated with a hiatus hernia. So remember that. On the other hand, this one is mesenteroaxial, where the pylorus is sitting up there, and then is the duodenum. I also warn you that when you are in the exam and the examiner might show you these volvulus on an axial CT scan, and you might be absolutely taken aback what's happening. So keep thinking and stretch your imagination, and it becomes very simple. The only thing is that the eyes do not, if you have not seen a particular entity on a particular modality, you at times find it very difficult to piece it together. So this is an axial of a volvulus, and this is the corona. So just wanted to warn you that on a CT scan, the same thing becomes a bit difficult. Now, the classical exam film, which might come in your exam, is the example here from StatDX, where this is a volvulus. So you pick up a volvulus, and you are very happy that you have picked it up, but the examiner is still not satisfied. Key thing here is to pick up, these foci of air. And these foci of air are intramural air. And candidate 4, what does it mean? What is happening?
There's air in the wall, so impending rupture or perforation, pneumatosis intestinalis.
Right. So this is means that the volvulus has strangulated and there is ischemia. So means there must be a twist of more than 180 degree. And now it is, impending perforation, or there might be a bit of perforation because there are some bubbles which are sitting outside. Next is candidate 5, and after candidate 5, I will ask candidate 9. So after 5, 9 should be ready. Thank you, candidate 4. Candidate 5, if you can raise your hand, please. And candidate 9, be ready. Candidate 5, you are with us?
Yes.
Over to you.
I'm presented with spot films from a double contrast upper GI barium study. There is an abnormality of the gastric mucosa of the region of the pyloric antrum, which is included, where the normal gastric folds are not evident, and the mucosa appears irregular.
What is happening here? I am interested in this region.
So within the generally irregular mucosa, there are small areas where there's punctate pooling of the contrast with a surrounding less dense area. They're multiple and they're small in size. They look like ulcers and they have the characteristics of aphthous ulcers.
What is your differential?
So it's possible that they are ulcers from another etiology, such as inflammatory or malignant, but I'd expect them to be larger in size and less multiple.
So what is top differential?
So my number one differential is aphthous ulceration in the context of inflammatory bowel disease.
Okay, fine. So I've already pointed out that whenever there is, infection or inflammation, you might have in the submucosa, you might have fluid attenuation. So this is a sort of a repetition. But coming back to the aphthoid ulcers can be seen in, let's say, gastritis. And this is endoscopy. You can see similar. What happens is that there is a ulcer, is a depression. Around that is edema of the mucosa. So similar thing projects here on a barium examination. In a dependent portion, the barium pools, and the edematous mucosa surrounded gives you this low density. So this is aphthoid ulcer. Now, aphthoid ulcer, this differential diagnosis, I believe, has been taken out from the present Chapman, because this is usually seen on barium examinations and it is not seen on other examinations like CT, etc. So you might not see it. But having said that, for me, it's still an important differential diagnosis for your exam. So this is from your old Chapman, and I want to warn you, in the Chapman, it is not mentioned that it can be seen in stomach. It is not mentioned it can be seen in esophagus. So I want you to remember like this. It is by definition a deep ulcer. It is an intramural deep ulcer, and Crohn's disease is the most common cause. Most common cause. So Crohn's disease can happen anywhere from the oral cavity till the anal canal. So in colon, in small bowel, in stomach, in esophagus. Other than that, if you see, other like non-steroidal, anti-inflammatory, etc., can also cause it within the stomach. Now, I want you to teach you, there are two differentials which again are not in your current Chapman, but they are important for barium examinations. And there was a lot of confusion about these two. One is aphthoid ulcer, and second one is target lesion. Target lesion in the stomach is a very important differential, and it will be seen on a barium examination. So if you see here, aphthoid ulcer is the ulcer crater and the surrounding edema. Basically, target lesion is something like this. There is a mound and there is a crater. I remember it like this, that simple to remember is that target lesion is a bigger volcano, and aphthoid ulcer is a very small one. So this is a aphthoid ulcer which you have already done. Look at this. This is a larger lesion. You can see that the crater, like this crater, is very large. Barium will go in, and surrounding edema will be there. And you will see, it might not be as numerous as this example. So and there is a differential diagnosis in your book. Again, this is the 6th edition. And here, please add GIST also. And I warn you that target lesion is an exam case. So I will tackle it because I have already told you, look at this. This is a classical target lesion where barium is sitting inside, and look at this, edema or the mound, which correlates with this thing. So, and the differential here is, most common target lesion differential is actually metastasis, but there are others here also. And this is a case of GIST, where you can see target lesion. This is a very good exam film. Over to candidate 5.
So I'm presented with a spot fluoroscopic image from an upper GI barium study. There is gross abnormality of the stomach, specifically the body and pyloric antral regions, with multiple areas in which there are pooling of barium with surrounding less dense halo suggestive of cratering or mucosal edema. I can see 3 such areas along the greater curvature.
Excellent. Excellent. What do you think overall? Are you happy with this appearance of the stomach?
No, so the mucosa is grossly abnormal, and the stomach does not distend as much as I would expect for this amount of contrast administration. So I think that there is evidence of generalized luminal infiltration with large target lesions. My number 1 differential is lymphoma, but other malignant infiltrations would be included.
Right, very good. So the point is that this is, there is loss of distensibility of the stomach. One of the exam tips in barium examination, and this is a key tip to remember, whenever you find something, particularly loss of distensibility, you have to tell the examiner that in my usual practice, I would like to confirm it on a subsequent film, because there can be technical reasons for under distensibility. If the examiner wants to show you, will show you, otherwise they will say, okay, fine, this was, persistent finding. So you have to, always ask for, is it a persistent finding or not? What is happening here, that there is loss of distensibility, and look at the mucosa. Mucosa is abnormal. This is a linitis type of picture. With that, one target lesion, second target lesion, and in a profile, third target lesion. And the differential will be metastasis. For example, please remember that this is, linitis. There are many causes of linitis. The most common is gastric carcinoma. But lymphoma and metastasis, particularly metastasis from breast, can also cause linitis. So this patient had both of the entities. Last film for you, and then we will take a 5-minute break. What do you think about the stomach? Over to you.
These are selected axial cuts from a contrast-enhanced CT of the abdomen, and there's one with lung windows. There seems to be gastric wall thickening with increased attenuation consistent with enhancement in the region of the mucosal side of the surface, surrounding some fluid that's within the stomach. For example, in the upper right image.
What's happening here?
So there's low density fluid within the stomach lumen, and in that particular section, there appears to be a discontinuity of the stomach wall.
Excellent.
And in that context, we can see free intraperitoneal gas and a small quantity of free intraperitoneal fluid. The overall appearances are of gastric perforation secondary to ulceration, which could be inflammatory or neoplastic in nature.
Right. So if you look carefully, if you see this antrum, candidate 5, you can mute yourself. After the break, it will be candidate 9. So be ready, candidate 9. So if you see here, you can see whole of this stomach is a bit thickened. This is the antrum. I do acknowledge that, this is because it's not completely distended. But having said that, here, definitely there is antral thickening. And if you see the continuity here, there is discontinuity. This was a case of linitis, actually, with perforation. And so this is a classical case which can come in the exam.